Welcome to Let's Talk Death, conversations to inform and inspire. Let's Talk Death is a series of conversations with some amazing people from various fields. Our goal through these conversations is to normalize, educate, and demystify the taboo around death, dying, and the journey of grief. Hello, welcome to this episode of Let's Talk Death. I'm Fran Solomon.
And I'm Andy McNeil.
And we are thrilled to be your hosts for these conversations. Let's Talk Death is brought to you by Heal Grief, a social support network creating community after someone has died. Everything we do is inspired by our core belief that no one should ever grieve alone.
Our goal with this program is to have a friendly chat with some amazing people so we can help normalize and educate our Heal Grief community. Our guest today is Dr. Akanksha Sharma. Dr. Sharma is board certified in the fields of neurology, neuro-oncology, and hospice palliative medicine. She is experienced in the treatment of primary metastatic brain tumors, neurological complications of cancer, and disease-related burden and symptoms. Dr. Sharma completed neurology training at the University of Washington, where she was chief resident and awarded the Dr. Alexander Spence Award for exceptional dedication to patient care, the University of Washington Cares Award for patient care, and the Resident Teaching Award. She then completed a 2-year research clinical neuro-oncology fellowship at the Mayo Clinic in Arizona, followed by a hospice and palliative medicine fellowship at the University of Washington. She has recently joined the team at Pacific Neuroscience Institute, where she is a neuro-oncologist and has also started a specialized clinic focused on symptom management for patients with cancer. Her clinical and research interests lie in helping patients maximize their time and quality of life. This means honest, transparent, and compassionate communication. Dr. Sharma, we are delighted to have you as a guest on our show.
Thank you so much. I'm very excited to be here.
So, Doctor, before we ask you about your work, may I ask, did you have a death loss that perhaps shaped your medical interests to include the hospice and palliative care work that you do?
Yeah, I did. My whole journey has really been driven by an experience, and actually I would say multiple experiences with patients, but one that is really close to my heart. So when I started my neurology residency, I really thought I was going to do stroke or intensive care. I really had never thought about neuro-oncology or brain tumor care. And when I was a second-year resident, I was consulted on a patient who had headaches. And I walked into the room and I'll never forget meeting her for the first time, or meeting her family for the first time. But this beautiful, vibrant sort of sunshine was like sitting in this room. And over the course of the year, I got to know her and her family really well. Her name was Janet Battles, and she would be completely happy with me talking about her, so I can share her name. She had just had a new diagnosis of breast cancer, and it was a really strange cancer because it was from the very beginning almost this liquid thing that was everywhere. And so when I'd met her, it was already in the brain, surrounding the brain. And it was a very unusual, she was a very unique and unusual person. And it was an unusual relationship. I got to know her and her family through the next year, and she used to consider me her fourth daughter. She had 3 daughters, so she would call me her fourth daughter. So I wasn't her physician at that time. I basically was part of the family because I just consulted on her and then she was discharged. And she was just an incredible person. I think that the biggest thing was that through that year, she made a lot of new relationships, including with me. She valued every moment that she had. She really wanted to celebrate Christmas. So we had 3 different Christmas parties. She wanted to create a lot of memories with her grandchildren. She had a new baby and an older granddaughter. She wanted to have memories with me, even though I was a new person in her life. And at the same time, she was very, she didn't mind talking about death. She talked about what her funeral would look like and where she wanted me to sit. And I was dating now my current husband. I was dating him back then, and she would tell him, like, if he didn't treat me well, she was going to come back haunt him. And so we had this amazing relationship. And then in April of last year, April 26th, she 2 days before that, she decided she was done. Her disease had really spread in her lungs. Really tried all kinds of treatments, but when the disease had gone to the point she was done, she said, I want to go home in hospice. And I won't forget that day either. I brought her a giant bag of popcorn, and she was like eating popcorn and crying and talking to her sisters and talking to me at the same time. And she went home on Friday, and by Saturday she was really sick, and we had consulted hospice, but no one had come yet. And her daughters were all, of course, non-medical. They called me frantic because there were no medications, and I had rushed over and I spent the weekend bedside but I myself was not a hospice or palliative care trained person. And a lot of things weren't in place that I wished had been, and I had never been told what to expect. And I was a doctor myself. None of us had been told what to expect. And I remember that whole weekend just watching her take it in this beautiful, graceful way that she always had. And my husband asked her for my hand in marriage at that time. She told me what my wedding should be. So she was going in and out, but there was so much that was lacking. I wish there was more that we could have done to make her comfortable in that weekend. And by Sunday morning, she passed away. And I remember going to my mentors and my teachers the next week and telling them, Jan passed away this weekend. And why weren't we better prepared? And everyone said, we didn't think it would happen so fast. We didn't think it would happen like this, or we we thought we had time. And that was a huge lesson for me, because she had leptomeningeal breast cancer, which is a diagnosis that has a very limited prognosis. And she lived almost a year with that. And so in retrospect, we had time, but those conversations were really hard.
Yeah.
One wanted to sit down and tell her this is what it would look like. No one wanted to tell her family that. It was very uncomfortable for all the providers, and I hadn't even thought about that. And so in that time, and over the next few years, I realized that she was guiding me towards this career. And I wanted to treat brain tumors, but at the same time, I felt that my role was going to be more than just treatment. I needed to walk with my patients from the beginning to the end, and make sure that no one felt that kind of fear and emptiness that we had in that moment where we didn't know what to do. And it's been 6 years now since she's been gone. And I think of her all the time. I have all these texts from her where I've been saying, like, I'm going to quit. I can't do this anymore. And she would say, you can't quit. You're my doctor. You're my daughter. You're my daughter. I have a voicemail from her, and I think of her all the time. And there are all these moments that I didn't get to have because I only met her for a year. But in that, it's just amazing how someone can change your life in that year. Her daughter got married recently, and there was a bottle of wine that Jan had left for her, and we all shared some of that and thought of her. So she was just incredible, amazing. I think she walks with me every day.
Thank you for sharing.
That was a long story.
I know that people listening are going to just really connect with that story and what you said there. And a couple of things that just strike me in that. One is that the honor it is to get to know a person, right? And when a person dies, how so much our focus is, yeah, but they died, rather than, wait, they lived. And I got the honor of knowing them. And because I knew them, in some ways, though they died, in some ways, they're still cheering me on. It's that kind of that continued bond that we feel with that person. And doesn't escape me to hear what you had to say, how compartmentalized sometimes we can be in medicine. And when I was reading your bio, I was like, wow, she's done so many diverse things as well, though focused on neuroscience, really so many other things that you did, and particularly that palliative care part that came out there. And I can't help but connect that to your story and the desire to know more about that so that there's that more seamless care, like you said, that we walk with our patients all the way through, and that is including to their death quite often in that situation.
Yeah, thank you. No, I agree. I think that when we get to know somebody, we often, I think initially in the grief period, we just focus on what we've lost. And I remember in the beginning, I was heartbroken. I thought all these other memories that people got to have with her, I didn't get to have with her. And then I realized what I had received and the amazing things she had given me, including an extended family that I still am part of. And I recently got finally married, and I wore purple at my wedding, and she really loved popcorn. So we had popcorn at the wedding, and I could feel her just everywhere. And I think how special is that I can, that I have this bond with this amazing, incredible person who really was, and I always, when I was interviewing for a job, I actually used her story as, I explained how her story led me to do both things. Because what I wanted to point out was that she lived her life expecting, she wanted to do everything. She wanted to live as long as possible. She never said, you know, I don't want to try this treatment or that treatment. But she knew her line in the sand. And she also was not afraid to talk about death and dying and the things that need to be done before she leaves. Like the legacy that she wants to leave, the memories she wants to build. And that's really, I now see how much courage that takes, but also how beautiful that can be for the people who are left behind.
Yeah. I was going to say,
yeah, if they have that option.
I was going to say that's a great opening to ask, you know, how do you, with all these families that are faced with their person that is probably not going to live for much longer, how do you bring that conversation in? It must be a very difficult journey for the families and for you too, always having to present that side.
Yeah, I think I always try to remember that it is how much harder it is for them to hear and for them to talk about than it is. I try to take my own discomfort out of it, but it is important for me to acknowledge it. I guess I would say that first, because I've seen my older teachers and mentors who, because it's so uncomfortable, that they want to avoid it. And it makes sense to me now that I've been doing this many years, because in the beginning it was like, we should do this. This is, you know, important conversation. And now there are days where I'm just like, I really don't want to walk in there and have that conversation. Yeah. But part of what has helped me is that this is my research. I research on how we can have that conversation. What point do people feel comfortable having it? How should we, what words should we use? How that communication should happen? What I've learned from both my training and my research is that it can't be one point in time. It has to be a conversation that slowly happens, especially in our cancer patients and our brain tumor patients, where it happens. It can't just be you walk into the room and say, I have terrible news, you're going to die, and you should get your affairs in order. Right? I mean, that's what the classic statement is that patients hate hearing. And that's when they come back and they say, you know, the doctor told me 6 months and look at me, I'm still here. The conversation really has to be in sync with who they are and what their families need. And that need changes in different times of the journey. And what I do is from the very beginning, I have a very open, from the first time I've met them, I say, you know, I want to know about your goals, your values, what are the things you're looking forward to, what are the things you're scared for, and this is a conversation we're going to have each time. And because I do that, it makes it easier for when things aren't going well to say, you know, it's my job to be honest. I don't think this treatment is working. So I want to make sure that we stay optimistic, but at the same time talk about where your goals are now. A few months ago, you really wanted to make it to your daughter's wedding. I think we should move that wedding, or we should change that plan. It's harder when I meet someone for the first time and they are not doing well. It's a lot harder. And I can see that conversation will not go as well, because I think you do need a bond and a rapport, and you need to understand how they want to hear it, when do they want to hear it, and also how much they take away. Because in that moment of grief and shock, you're not going to take away and absorb what the doctor is trying to tell you. So that's sort of how I try to have that conversation. And the other thing I've noticed is that asking permission and asking what people want to hear is really important. Like when I was a resident, actually, I started realizing that patients' families were really afraid to ask, but then when they felt comfortable, they'd say, well, I really want to know, how do people with brain tumors die? And no one had ever talked about that. They're like, what exactly is it going to look like? Am I going to be scared? Should I have my children visit or not? Is there going to be vomiting, breathing, like very practical things that they wanted to know, and they were afraid to ask because that question makes them feel like they're being negative. And so I ask permission a lot. I say, is it okay if I talk about it? Is that something you want to know? And sometimes I'm surprised how many times people say, yes, I really wanted to know that. Or sometimes some people say, well, I think he or she wants to know, I don't want to know. And so then we have separate conversations.
Yeah.
Interesting. So you've gone into my, my second question, which was really about that research you're doing. But then you've also been involved in numerous clinical trials, and you're initiating several studies of your own research. Was that it, or are there additional studies, and what might you be able to reveal thus far?
So one of my, I think what I find to be the most interesting studies was I did a fellowship. So we were looking at the Mayo Clinic, with my mentor, Dr. Alex Porter, we designed a trial where we looked at patients who had high-grade glioma or glioblastoma, so very aggressive tumor. Senator McCain had it, and it has a generally very poor average survival, median survival. And it's the kind of tumor, especially in Arizona at that time, that you could Google and you would see a lot of information out there about it. Generally, what's quoted is 15 to 20 months after diagnosis in terms of survival. So what I was curious about was, are we talking about prognosis with patients? Are they ready and expecting, and are they preparing for the things they're ready for? So we asked our patients and their caregivers and their doctors how much time they thought they had. So what we know from information from cancer research in general is that doctors are terrible prognosticators. We are not very good. We can't look at, it's not just the magic 8-ball. Even the people who try are way off. Either what's interesting is that if they know the patient well, they tend to overestimate. And if the patient is doing really well, like healthy, walking around, we're really inaccurate. The only time we get accurate is when someone's really doing poorly. And so I was curious, how is it in brain tumors? Because brain tumors can get even more complex because there's cognitive changes, all these other changes. And the other thing I was curious about is, what do patients and caregivers think of this situation? And so we asked everyone a question every month. We would say, if you had to guess how much time you had left, what would you suggest? What would you pick? Months to years, years to months. And we kept it very vague. The main goal of the study was to actually ask, can we ask a question about this without offending people, making people scared? And it met that goal. Like, no one at any point was like, how dare you ask me this? Or why are you asking me this? Everyone was okay answering that question. But then the other part that ended up being really interesting was how much it changed. So at one point, all of these patients had a conversation about prognosis. As I said, it's information that's available online, but we would range from days to weeks to months to years, and then back to days to weeks, and then it would be indefinite number of years. It was just all over the place in terms of patients' opinions. I had an 87-year-old and a 23-year-old, and they both thought they were going to live indefinite number of years. Every month they would say, I'm going to live indefinite number of years. And then, so it was interesting, the caregivers tended to be a little bit more pessimistic. The patients became more optimistic. The sicker they got, they were more optimistic, which I think is also really interesting.
That is interesting.
Do you think it's the hope?
And that's the thing, is the next step is to figure out what is it. And I do think it's the hope. And hope is really interesting in brain tumor patients, because there's a study from the 80s that found that patients themselves created this feeling of hope and optimism in their brain, especially when they had a glioma. It's the brain's own defense mechanism to what's going on. Like, there's so much going on inside the brain. It's very different from systemic cancer. You know, you have cancer at one area. I mean, not just, but you might have it in the body. But this is happening within your brain. So there has to be changes that really affect your perception and insight. And the reason this study was important to me is so many wives and husbands and children had said, you know, I know that she's not doing well, but she seems really happy, or he seems really happy, and he doesn't know. And it causes this disconnect towards the end of life, because a lot of times you can't sit down and say, you know, we had a great life together. I really love you. I'm really grateful. I don't know how we'll say goodbye, because the patient will be like, goodbye. Like, what do you mean? I'm going to live many more years. And that was a theme I was seeing again and again, especially when I was doing hospice work. And so I wanted to recognize that for the caregivers, that that is a real thing that's happening. And that it's challenging. Like if you don't, not that I'm saying that it happens in all brain tumor patients, but in the patients where it does happen, it changes that dynamic, and it doesn't give you those moments of goodbye that you wanted to have.
Interesting.
Well, Dr. Sharma, we only have a few minutes left. I'm curious if someone listening to this episode would like to connect with you or your work, how might they go about doing that?
So I'm currently at Pacific Neuroscience Institute. I found a great support system here. So interestingly, the type of kind of research I do is not always very popular in the brain tumor world. So we're finding Dr. Kesri and his team has been very supportive here, Dr. Kelly. So we are starting to do trials here, hopefully in the next year. A lot of our research will be focused on symptoms, patient symptoms, caregivers burden. So we would love to, if these are things that resonate with you, you can connect with Pacific Neuroscience Institute, with our Brain Tumor Center online, PNI, and we can definitely see you here. It doesn't have to be for treatment. Our goal here is to walk with patients who have brain tumors, regardless of if they're getting treatment here or not. So we welcome anybody.
And we did have the pleasure of having Dr. Kesri on, and he was saying that he's looking to bring the treatment to the patient, not necessarily burden the patient with having to come to the center. Yes,
yeah, that was one of the reasons I really, the mission of the program really went with mine, because it is so true, is that you don't have access depending on where you are in an area. So I would, we're very fortunate we can bring a lot of trials to people in Southern California.
Wonderful, wonderful. Well, Doctor, we want to thank you so much for being a guest here at Let's Talk Death, and for sharing the inspiration behind your work and the development of it. It's remarkable. It's great work.
Thank you so much. It's been really fun, and it's really flew by. So thank you so much for having me. It's been a huge privilege. Thank you for the work you do. I think having support with grief is just one of the most important things.
Thank you.
Thank you. And thank you to those who are joining this episode of Let's Talk Death. If you would like to learn more about Heal Grief, visit us at healgrief.org. At healgrief.org, you can learn more about all of the programs and resources of Heal Grief, including our national network of support of grieving young adults, a program called Actively Moving Forward.
And if you know of a bereaved adult, refer them to the AMF app, where adults of all ages connect with others experiencing a similar death loss. And last, make sure to sign up at healgrief.org to receive our newsletter and links to future episodes of Let's Talk Death.
And so with that, again, thank you for joining us, and we will see you next time on Let's Talk Death.